Okay, so now we will be talking about dumping syndrome. Dumping syndrome is basically the combination or constellation of symptoms that occur after the accelerated movement of hyperosmotic content of the stomach from the stomach to the jejunum. Okay, so dumping syndrome occurs as a complication of the gastrectomy, and especially the Bell-Rod 2 gastrectomy, in which we connect the stomach, we remove the some of the part of the stomach, and the other part of the stomach we connect it to the with the jejunum. So it is basically the gastrojejunostomy. The main function of the stomach is to store the food for some time and to mix the food contents, but in the and then a slow transition of the food content, stomach content, from the stomach to the duodenum. But in the after the Bell-Rod 2 surgery, the stomach content immediately leave the stomach and go to the jejunum. So the food content there is hyperosmotic, and when the hyperosmotic content goes to the jejunum immediately, it will cause the symptoms which is collectively known as dumping syndrome. Now the dumping syndrome occurs in two ways: early dumping syndrome and late dumping syndrome. After ingesting the food content, the hyperosmolar contents into the stomach, so after 15 to 30 minutes of ingesting the food, early dumping syndrome occur, which is due to the hypovolemia. Why hypovolemia occurs in the dumping syndrome, early dumping syndrome? It is basically due to the hyperosmolar contents, the flow of hyperosmolar contents from the stomach to the jejunum. And as a result of hyperosmolar content in the jejunum secrete a heavy amount of secretions. About 2 to 3 liters of secretion is released from the jejunum, and this result in the third space lossing and the hypovolemia. So the symptoms of early dumping syndrome is due to the hypovolemia, while in the late dumping syndrome, after ingesting the hyperosmolar content into the stomach, the late dumping syndrome occurs 2 to 3 hours after ingesting hyperosmolar content. And it is the symptoms in the late dumping syndrome is due to the reactive hypoglycemia, because the hyperosmolar content in the jejunum causes the insulin to raise, and insulin causes the reactive hypoglycemia, and as a result the symptoms of hypoglycemia will occur. Now, how we will manage the early dumping syndrome? As it is due to the hypovolemia, so we will give IV fluids, while the late dumping syndromes, as it is due to reactive hypoglycemia, so we will give oral fluids. But we can prevent the dumping syndrome by some of the managements with the help of some of the steps. The first step in the prevention of the dumping syndrome is to bring the dietary modifications in the patient's life. We will advise some of the dietary modification to the patient, like the frequent small meals. Okay, so at one time the patient should not ingest the heavy meals or hyperosmolar meals. Like we will advise the patient not to consume the energy drinks, and we will advise the patient not to ingest the high carbohydrates, but instead we will advise the patient that to consume the high fats and high protein diets. Okay, and if the dietary modification fails to improve the patient's condition, then we will go to the second option, which is octreotide intake. As octreotide is the analog of the somatostatin, so somatostatin analog octreotide will inhibit the secretion from the jejunum, and it will also inhibit the release of insulin as a result of hyperosmolar content in the jejunum. If the octreotide intake is failed to improve the patient's condition, then we will go to the surgery, and the surgery is the treatment. The surgery of choice is that we will convert the Bell-Rod 2 into Bell-Rod 1.